Let's step into the OR to explore the VIA 360 surgical system up close, from setup to surgical technique to key pearls for success. I'm Dr. Constance Okeke, and this is MIGS Inside the OR, where we turn innovation into surgical precision. Let's start with the setup for the VIA 360 procedure. This patient was set up for a combined cataract extraction with VIA 360. A clear corneal incision was made, and then uneventful cataract removal, and then IOL placement, followed by viscoelastic instilled into the anterior chamber. Maintaining a stable chamber is essential to preserve your angle view and allow for controlled device entry. Visualization. I sit superiorly for cataract surgery and then move temporally for my MIGS approach. Take your time here. Optimize the patient's head tilt and microscope angle tilt and your own positioning. This ensures that the rest of the case flows easily. Then use a gonioprism with viscoelastic to obtain a clear view of the nasal angle setup to see all of the angle structures. Next, I like to advance the catheter tip and then test the viscoelastic outflow by pressing on the device button. This helps me to ensure that my assistant has primed the device correctly. Let's look at ergonomic positioning. Adjust the tip of the handpiece by rotating the cannula to an angle that feels comfortable in your hands. I like to have mine bevel up about 20 degrees. Next, tilt the device diagonally to the side. You want to avoid holding it without a tilt because pressing the button here causes vertical tip motion up and down. With a diagonal tilt, pressing the button moves the tip horizontally along the wall of Schlemm's canal. Device insertion and canal entry. Enter the tip of the device through the corneal incision, then place the gonioprism on the surface. The VIA 360 handpiece is then advanced towards the trabecular meshwork. Increase the magnification and center your view. The device tip should press against the TM to score it and puncture, creating a small goniotomy. Shift the tip slightly back and then enter through to the Schlemm's canal and begin to advance the catheter into the canal. Canalization. This is done by rotating the wheel forward to advance. Watch the catheter track in Schlemm's canal to make sure you're in the right position. And as you do feel, look for any resistance. Periodically, you'll press the button to release viscoelastic. Watch for any patient grimace that may indicate you're in the wrong position. Maintain the view of the tip pressed against the back wall of Schlemm's canal. Keep a watch of the catheter as it approaches the tip, reaching 360 degrees. Then retract the catheter, rotating the wheel in the opposite direction. This process will go much faster than moving forwards since the canal is already open. When you begin to see the catheter holes in the tip, you know that you're near the end. Trabeculotomy, creation, and completion. Begin to then advance the tip in the canal again to the appropriate length if you plan to do a trabeculotomy. I reduce magnification and remove my gonioprism for a wider view, and then I pull the catheter down, keeping the tip close to the angle to unroof the trabecular meshwork. At this point, one could be done with the case, but if you desire to perform more trabeculotomy, or if you had hit resistance at some point, you can consider treating the canal from the opposite approach. To do this, rotate the device tip to the appropriate position and diagonally tilt the device in your hand. Then reinsert the tip through the corneal incision. Apply the gonioprism and then advance the tip towards the trabecular meshwork. You can enter through the opened area of Schlemm's canal by pressing the tip against the back wall of the canal. Once the tip is in the canal, advance the catheter by rotating the wheel. Here, I pull to perform additional trabeculotomy. Again, removing my gonioprism and pulling down towards the angle. Additional pearls. One thing I also like to do is after I've completed a trabeculotomy or even a goniotomy is to go back with my gonioprism and viscoelastic on a cannula and reapply additional viscoelastic directly to the area that I've opened. I believe that this step helps to further flush the Schlemm's canal and the collector channels for maximal outflow. Completion and closure. After this step, I will tilt the patient's head, then rinse any viscoelastic on the corneal surface to enhance my view. I will then use irrigation and aspiration to thoroughly remove viscoelastic. I take my time with this step, which helps to prevent post-operative pressure spikes. While I am doing this step, I will also watch the nasal area to look for signs of flushing within the episcleral vessels. This can often be a sign of good opening of the outflow system from the procedure. Also, while I'm doing this step, I will look to see if there's any significant egress of heme into the anterior chamber. If there is, I will consider using sugarcane at the end of the case, which contains epinephrine in it, which can aid and work as a vasoconstrictor of the vessels to help reduce bleeding. I will also hydrate the corneal wounds so that the anterior chamber is pressurized to about 30 millimeters of mercury. You can see the rise in the pressure by tapping on the corneal surface with a cannula to look for resistance with the pressure or how firm the cornea is. This aids in helping to tamponade vessels and prevent postoperative hyphema. I will check my wounds for any leaks, and then I will insert my antibiotics and steroids, and then again I will also watch for blanching at this time. I again make sure that all my wounds are hydrated and check for leaks, and once confirmed, I also look to see that the pressure is high. I then go ahead and place a clear bandage contact lens on the surface of the eye. This will help with faster healing of any incisions that were made, especially if there are any mild corneal abrasions. It helps to heal them faster. It also provides comfort for the patient to allow them to have a better experience. I let the patient know that if it falls out, they do not have to put it back in. I let them also know that we will take it out in the clinic setting, which typically happens anywhere from the first day to at the post-op 1-week visit, since they are routinely on antibiotics through that period. Okay, so now you've seen the VIA 360 in action, from setup to pearls that enhance every case. For a quick pre-op refresher anytime, visit MIGS in Minutes for VIA 360. For reviewing some of the most common VIA 360 challenges and how to overcome them, watch MIGS Success Surgical Secrets Season 4 on VIA 360. And if you'd like a simplified version to share with your patients or staff, watch MIGS Glaucoma Made Clear. I'm Dr. Constance Okeke. Thanks for watching.